I'd like to welcome you all to our webinar today on understanding the complexities in the Indigenous health crisis. My name is Sean Fitzgerald. I'm speaking today from Jasper, Alberta. I'd like to begin today's meeting by acknowledging that the College of Physiotherapists of Alberta's offices are located on Treaty 6 territory, as well as the Métis Nation of Alberta's Region 4, which has been and continues to be the home of many Indigenous peoples since time immemorial. The College of Physiotherapists of Alberta recognizes that Indigenous peoples have been helping many live healthy lives on this land long before settlers arrived. With that, we commit ourselves to helping move people forward in their journey towards a good life and doing so in a way that follows the spirit and intent of treaty, that of peace, friendship, and understanding. We also recognize that people from across Alberta and beyond are joining us today and encourage you to take a few moments to learn about the lands, peoples, and trees with which you may be in relationship. I have the pleasure of introducing our speaker for today, Randall Bell. Randall is a member of the Montreal Lake Cree Nation in Saskatchewan and the son of a residential school survivor. Randall is currently employed by Alberta Health Services as a senior advisor for addiction and mental health at the Provincial Indigenous Wellness Corps and has recently led the development of the Indigenous Addictions and Mental Health Wellness Strategy for Alberta. Randall holds a bachelor's degree in social work, a master's of public health, and will be starting his PhD at the University of Alberta this fall. Again, welcome, Randall. Glad you could finally get in here, and I'll let you take it over from here.
Perfect. Thanks for that, Sean. And thanks for having me here this morning. I think I need you to mobilize share. Mobilize activate or... Okay, here we go. Screen one, share. Then I go to slideshow from the beginning. Then swap. Does that look right to you guys? Sean?
Yeah, looks perfect.
And you can't see my notes?
Nope.
Okay, perfect. You can't see my cheat sheet, so we'll go ahead and jump right in the interest of time. Mio Casipio, Asini Masqua Nesatigasun, Muniao Sagahiginik, Isigitu, Mitaskitan, Nihidao Nia Montreal Lake, Nihidao Nation Oche, Oti Saskatchewanak. Hello and good morning. Stone Bear is my Cree name. I'm a member of the Montreal Lake Cree Nation in Saskatchewan, over in Saskatchewan. And I'd like to start out by thanking Sean and by thanking Leanne for having me here today to share this message with you. And I'm aware we have limited time and we've already wasted much of that trying to get out the technical issues here. So I want to leave as much time as we can for those conversations afterwards. As I always say, we cannot have reconciliation without conversation. So with that, Egua, let's go, as my mother would say. She says it like a drill sergeant, so I'll spare you the indignity. Today's discussion. Today, we're going to be talking about the trauma of Indigenous people, Indigenous intergenerational trauma, adverse childhood experiences, social determinants of health, the Indigenous health crisis, and reconciliation in healthcare, what we can do as physiotherapists in our role in reconciliation. And I don't want people to roll their eyes thinking this is another residential school presentation, because it is not. I do believe this is much, much more. Nature or nurture? Now, this is a picture of two of the whitest little treaty Indians you ever saw. There's a picture of me, Sini Musquat, and my daughter, Mackenzie. Her Cree name is Piwapan, which means sunrise. We've both given our names through Cree ceremony at very young ages, her shortly after this picture. And you can see genetics at work in this picture. By the end of this presentation, I'm sure you'll form an opinion one way or the other, whether she was blessed with really good genetics or cursed with really bad ones. But let's talk about genetics for a second here. 11 years ago, researchers blew the scent of a cherry blossom into the cages of adult male mice while zapping their feet with electricity. And after being zapped a few times, these traumatized mice associated the smell of cherry blossoms with pain. Now, these traumatized male mice were bred with females, and when their pups smelt the scent of the cherry blossom, they became jumpier and more nervous than pups whose fathers had not been traumatized. Well, maybe they learned this behavior from their parents. No, they were raised by unrelated mice who had never smelt the cherry blossom. The second and third generation didn't fear the scent itself, but had a heightened sensitivity to it. And so the finding supports this theory that the next generation doesn't always show the exact same trait that their parents had. It's not the trauma that is being passed down to the next generation. It's not the fear that's being passed on to the next generation. It's the fear of a scent in one generation that leads to a sensitivity in the next. Now, another study went a step further, and they extracted RNA molecules from the sperm of male mice who had been traumatized, and they injected them into the embryos of mice whose parents had never been traumatized. The resulting pups, however, still showed that typical altered behavior pattern of pups whose parents experienced extreme trauma. So we'll come back to mice and cherry blossoms, and we'll consider whether or not the epigenetic effect of trauma is real. But I can tell you from my own personal and professional experiences that the connection between historic trauma and the current Indigenous health crisis is as real as the rivers and the rocks. So what is historic trauma? Well, Michelle Sotero has defined historic trauma in 3 stages. The initial phase, that dominant culture perpetuates mass trauma on a population in the form of colonialism, slavery, war, or genocide. Second phase, the affected population shows physical and psychological symptoms in response to that trauma. And in the final phase, the initial population passes these responses to trauma onto subsequent generations who in turn display similar symptoms. So by now you're probably thinking, these phases of historic trauma are very similar to the epigenetic responses that were observed in the cherry blossom mice. And you'd be correct. This is a now famous painting by Kent Monkman called The Scream. It is undeniably visceral depiction of that exact moment people like my mother were ripped away from their family and home and shipped off to residential school. In the 1950s, my musha, my grandfather, had spent 5 years in prison for killing a moose off the reserve. And when he was released, he was deathly afraid of the RCMP, and he was deathly afraid of going back to prison. And so when the police and the residential school administrators came and took away his children, he said nothing in protest. And after about a month at residential school, my mother and my Aunt Ginny ran away, traversing some 50 kilometers of unforgiving northern Saskatchewan forest to make it back to their home. A few days later, the police showed up at the trap line with a school administrator. And when the school administrator caught my mother, he bloodied her nose in front of my grandfather. She was 7 years old. My mother said her father did nothing in her defense, and she never forgave him for that until she was in her 40s. She had figured, it had taken her that long to figure out that the police, that the RCMP, and that the prison system had broken him. He knew he was powerless against the colonial government. And so my mother was taken back to residential school. So this is my mother. Her name is Eagle Whistle Woman. Ivy is her name. Ivy is a Cree woman from Montreal Lake, Cree Nation. Ivy suffered every kind of child abuse imaginable in the community she was raised in, and she suffered more of the same when she got to residential school. As an adult, she suffered 3 years of domestic violence. Most of her adult life, she struggled with PTSD, anxiety attacks, depression, suicidal thoughts, and a number of different physical ailments. Now, to cope with traumatic memories and emotional pain, Ivy self-medicated with substance use for many years. But she found a way out. At 32, she left an abusive partner and went back to school with her little grade 9 education. She finished her GED. Now, a single mom with 3 hungry kids, she went on to university. So at 35, she finds Indigenous culture and she adopts a traditional Indigenous lifestyle free from substance use. And after finishing a bachelor's degree in social work, she proceeds to her master's. She's now been a successful self-employed mental health therapist for over 20 years. She's traveled all over the world, seeing many of the places she only dreamed about as a child. She's achieved many of the goals she once thought impossible. My mother's story is one of strength, courage, and ultimately hope. She personifies resilience. But as we examine the Indigenous health crisis, you'll see my mother is an exception rather than the rule. 120 years of traumatized children. So my mother's traumatic childhood is not unique. Indigenous people have been exposed to over 120 years of colonization and assimilation policies, and the legacy of those policies are alive and well today. There were over 150,000 Indigenous children that were taken away from their families and placed in residential school. The odds of returning from World War II were 1 in 26. The odds of dying in a residential school were 1 in 25. Thousands of residential school survivors would later recall incidents of physical, emotional, and sexual abuse, underage pregnancy, starvation, malnutrition, torture, and even murder. People always ask at the end of this presentation, what's this torture thing? Were they tortured? There are many, many incidents of recollections through the TRC commissions that spoke specifically to torture and murder. Probably the biggest example that I can think of was a residential school in Quebec. In the furnace room, they found a small, tiny electric chair. So there was definitely incidents of torture and hundreds of accounts of murder witnessed. The 60s scoop, 1960s, means another 20,000 children are away. The millennial scoop in 2000 meant another 22,000 children taken away. Of course, we have the modern child welfare state with 53.8% of all children in foster care being Indigenous. In 2021, the Honorable Dr. Carolyn Bennett said there are more kids in care now than there were ever in care at the height of residential schools. It's unacceptable and it's harmful. But to understand how all this trauma affected people like my mother, we first need to appreciate the health consequences of adverse childhood experiences, ACEs. Well, what are ACEs? If you're not familiar with Dr. Vincent Felitti, between 1995 and 1997, Dr. Vincent Felitti led a study of over 17,000 adults in California. And these participants completed confidential surveys regarding their childhood experiences with the 10 elements of trauma that are listed here. The study showed that childhood traumas or exposure to these traumas led to poor health outcomes and social problems later in life. The more trauma they had, the more health problems they developed. Essentially, a child survives a traumatic adverse childhood experience, is exposed to toxic stress. That child then has disrupted neurological development and response, struggles with social, emotional, and cognitive impairments. They don't fit in well with the other children. I'm sure some of you who have worked with children, Indigenous children, will have seen the children that I'm talking about. Some of them will have delays in speech. Some of them will have delays in physical development, mobility, motor skills. These children don't fit in with the other children. And later in life, in their teenage years, they cope with this through high-risk behaviors, things like habitual substance use. And over time, trauma and all that comes with it becomes autocatalytic, eventually leading to chronic disease, disability, or social problems. And ultimately, it leads to an early death. The presence of high ACE scores in childhood are now commonly associated with higher rates of obesity, higher rates of cancer, diabetes, heart disease, COPD, higher rates of addiction and mental health issues, higher rates of incarceration, and even homelessness. Now, if this doesn't blow your mind, a 2022 study looked at 1,679 adults in Philadelphia. They found that adults with more than 4 ACEs, which is reasonably low, comparatively. For ACEs, they tended to live in neighborhoods with higher neighborhood poverty, less socioeconomic resources, worse food access, poor perceived physical and mental health, more substance use and overdose death, higher rates of crime, even less green space. You can literally predict which neighborhood someone lives in based on their ACE score. So we start to see that this isn't about personality deficits or a lack of motivation or even laziness that they don't want to work. This has everything to do with their childhood and their adverse childhood experiences they had. But understanding the Indigenous plight goes beyond learning about residential schools, and it goes beyond learning about ACEs. It's about understanding the cycles of trauma that started and the effect of those cycles later in life. My mother had stopped the substance use. She left an abusive situation. She went back to school. She found her spirituality and her inner strength, but by then the damage to her children was done. Our adverse childhood experiences. So like my mother before us, all three of us would score or would likely score 10 out of 10 on the ACEs study, the highest level of trauma that you can be exposed to. We grew up in an extremely dysfunctional household with an extremely abusive stepfather. Substance abuse and domestic violence were commonplace. We suffered many forms of child abuse and neglect. It was an unpredictably violent place, devoid of safety, structure, or stability. We experienced extreme poverty and food insecurity on a daily basis. And it's important to understand now that my mother had the same childhood as her siblings, and they suffered many of those same adverse childhood experiences. And so the story of my extended family isn't any different from our own. 5 of my cousins are my age. They went to residential school. Some of them were younger than me, and they went to residential school. At least 20 of my cousins have been in foster care and or had their children in foster care, like my sisters and I. 3 of my cousins were murdered before they were 25. 2 of my cousins have mothers who are missing murdered Indigenous women. 1 of my nephews recently died in a fentanyl overdose. 5 of my other nieces and nephews have survived fentanyl overdoses. And so through the course of my career and my adult life, I've sought to understand why our family is so different from yours. What the hell is wrong with us? Why is our family so dysfunctional? Well, in 2016, a brilliant young man, I was a lot younger back then, led a study that looked at Indigenous high-need service users. And when I say high-need service users, I'm talking about homeless Indigenous people on the streets, multiple episodes of care and other addictions or mental health facilities. And to understand this graph, you look at the inner ring that represents their childhood. The middle ring represents their teenage years, and the outer ring represents their adult years. The number in there is a score on 1 to 100, representing their exposure to those different traumas. You see, I understood immediately after reading Felidi's study that Indigenous trauma doesn't end in childhood. It accelerates. It grows exponentially. And these graphs prove exactly that hypothesis. It's no surprise that there were adverse childhood experiences in Indigenous populations, people living on the streets. But what is interesting is that in most cases, those trauma exposures do grow. And at the time we thought the levels of this trauma as bad as it can get. Then we interviewed 100 high-need service users who were incarcerated in Alberta. And we saw patterns of trauma exposure that were even worse. As you can see, the levels of trauma exposure more than double the high-need service users in some of these categories. 98% indicating they had a substance use problem, 95% indicating they had suffered from anxiety, depression, suicidal ideation, panic attacks, PTSD, insomnia. And here's the really important part. Of the 200 people that we interviewed, Indigenous homeless people with multiple episodes of care in addiction or mental health facilities, of those 200 people, 41% of them were residential school survivors. 75% of them had a parent who was in residential school. You know, when we learned about Kamloops 211, there were so many people that were saying those poor children, if only there was something we could have done for them. If only we could have helped those children. There are 12,000 of those children walking the streets of Alberta every day. Most of them are pushing shopping carts and are homeless. So I ask, you know, when you're out and about in your daily life, grabbing your groceries from Sobeys and you see that homeless person pushing a cart, remember that there's probably a 41 to 70% chance that person is a residential school survivor with multiple episodes of mental health issues. So many of those survivors were, and if they hadn't gone to residential school, here's the other part. Well, what about that other 40%, that other 30%? Most of those survivors, most of those people we interviewed were survivors of the 60s scoop and had grown up in multiple foster homes as children. How do you quantify multiple? It is over 5. So when you see that person pushing the shopping cart, they're a residential school survivor, their mother and father were residential school survivors, or they had gone to over 5 foster homes growing up. The other thing that we came across is that most of these people we interviewed recalled the loss of or disappearance of a significant female figure early in their lives. Does that sound familiar? It should, because they're usually called missing murdered Indigenous women. All the women and men that we interviewed have or had children who were at the time growing up without one of their parents. And so again, what do you think happens to those kids when they're not growing up with their parents? You know, this is where this cycle starts. And where are those kids going to end up eventually? Excuse me. So we know high ACE scores increase the prevalence of health risk behavior. We understand that ACE's exposure pushed the risk of chronic health conditions even higher. How higher? Well, arthritis, even something as mundane as arthritis, if you have 4 ACE scores or higher, your odds of getting arthritis increase by 236%. COPD, 4 ACEs or higher, you have just about a 400% chance of getting COPD. My mother was diagnosed with COPD about 10 years ago, developed into lung cancer. So you see in the third row here, cancer, 157%, followed by COPD. Interestingly enough, about a year ago, I had a cardiac episode and I was going through a lot of tests. One of them was a 24-hour blood pressure monitor. It checks your blood pressure every 30 minutes. And so I'm doing this, this same presentation at the University of York. And I'm in the middle of this talk and my blood pressure monitor starts vibrating and checking my blood pressure and it makes this loud noise. Initially, I was kind of embarrassed by this noisy disruption. I apologized. And then it hit me. It was the very first time that I had seen myself in the very statistics that I was talking about. I've always been a competitive athlete in terms of my own health, I suppose. I thought maybe I was an exception to the rule. And now I know I'm not. Neither is my mother. She has arthritis, asthma, COPD, lung cancer. She just had a stroke. Over the holidays, she moved in with me as she was doing her chemotherapy. She had a heart attack. And so, you know, looking at this chart, we know that people like my mother, people like me, are at extremely high risk of developing these chronic conditions. And it just goes to show, really, you can outrun your history, but your biology will catch up eventually. So it's all about trauma? No, it's not all about trauma. In the case of Indigenous health crisis, we're talking about a fire that was started, but it's the social determinants of health that keep that fire burning. What are the social determinants of health? Well, typically when we say social determinants of health, we're talking about food security, income, education, employment, housing, and social context, community context. If you've ever been on a reserve, you'll know just how supportive and rich and vibrant those communities look. When we have good determinants of health, we have lower health risks. We have better health outcomes. When we have bad social determinants of health, we have bad health outcomes. Reasonably simple, right? Well, 28 years ago, the Royal Commission on Aboriginal People raised the alarm on poor social determinants of health and poor Indigenous health outcomes. They begged the government of Canada to do something about it. So let's take a look at how much things have improved. In 2019, the proportion of Indigenous people with moderate to severe food insecurity was more than double the rest of the Canadian population. 2015, Indigenous people, Indigenous communities were age 15 or over, had a median income of just $16,000 compared to the median income of non-Indigenous Canadians at $34,000. I was hoping for new numbers in the 2021 data that came out, but they're all misleading with the COVID relief money. Anyways, poverty is a barrier to health services, and putting food on the table for your kids is always going to take priority over seeing a doctor or a physiotherapist. You might have had Indigenous children or Indigenous patients habitually missing their appointments. And this is a good example of that. It's putting food on your table or putting clothes on your kid's back is always going to be a priority over getting in to see the physiotherapist. Social determinants of Indigenous health. Poor education and training opportunities affect Indigenous health. 31% of people living in Indigenous communities are considered low income, compared with only 11% of non-Indigenous Canadians. Unemployment rate, 3 to 4 times higher than non-Indigenous Canadians. So no job opportunities, no chances to get ahead. Safe and adequate housing affects Indigenous health. In 2021, 37% of people in Indigenous communities lived in homes requiring major repairs, versus only 12% of non-Indigenous Canadians. Poor air quality and black mold obviously contributing to respiratory diseases like asthma or COPD. In 2021, 35% of people in Indigenous communities lived in crowded homes, compared to only 9% of non-Indigenous Canadians. Big housing shortages on reserves, and so they all live together, large families, small houses, and all that moisture has nowhere to go, so it turns into black mold. And these houses quickly get worn out as they're overcrowded. Overcrowding also contributing to an alarming rate of infectious diseases in Indigenous population. And so we start to think about how dangerous COVID-19 was when you had houses that couldn't isolate from each other, households that couldn't isolate from each other, and large households. According to the federal government, there are more than 100 drinking water advisories, still in effect for First Nations across Canada at any given moment. So is it any wonder then that the rate of waterborne diseases in Indigenous communities is 26 times higher than the national average? This is a chief here of Little Saskatchewan Reserve in Manitoba a few years ago. A Health Canada staff member told him the water is fine to drink, but a private lab said he wouldn't wash his dog in it. Heart disease. The Heart and Stroke Foundation of Canada states that heart disease rates for Indigenous people are as much as 50% higher than non-Indigenous Canadians, and the death rate from stroke is twice as high. 2018, Indigenous rate of diabetes is 2 times higher, tuberculosis 34 times higher, and Inuit populations is 290 times higher. Age standard hospitalization rate for people living on reserve is 2.7 times higher for Indigenous females. 2.4 times higher for Indigenous males. But what about addictions and mental health? Well, here's where it gets really depressing. The rate of mental health hospitalization is 3 times higher. Rate of hospitalization for intentional self-harm, 7.3 times higher. The rate of suicide for Indigenous adults is 3 times higher. A couple of years ago, there was an Indigenous community south of Edmonton. There's 10,000 people. And it went through a 3-month stint where I was having 70 suicides. Sorry, 4 months. So over 4 months, they were having 70 suicides a month. I visited that same community. I won't name it. I visited it about a month ago, and I went to Tim Hortons to get a big box of donuts for the meeting. And the Filipino staff said, this gentleman here would like a wake box. And I said, why did you call it a wake box? And they said, oh, sorry, whenever there's a death in the community, they have a wake. And everybody comes in and buys a big box of donuts. So we just call them wake boxes. So in the United States, Baltimore, Maryland is the epicenter of opioid death in America. They have 170 deaths per 100,000 people. This is a city of 569,000 people. Currently in Alberta, there are 6 opioid deaths a day. But of the entire Alberta population, there's only 284,000 Indigenous people. And we have a death rate of 205 per 100,000. So you heard that correct. The very worst city in the United States has 170 deaths per 100,000. Among Indigenous populations in Alberta, we have 205 per 100,000. So there are more Indigenous people dying per 100,000 than the very worst city in the United States. And with the rate of Indigenous opioid poisoning deaths, that is 8.5 times higher than non-Indigenous Canadians. Multiple communities have declared states of emergency in response to the opioid crisis. It's where these wake boxes have come from. And we could see here, the blue line being non-Indigenous Albertans, the green line being Indigenous Albertans. It's shockingly higher. But what's really shocking is these numbers don't include Indigenous people who don't have a treaty card. It doesn't include Métis people. It doesn't include Inuit people. So this graph literally represents the tip of the iceberg when we talk about opioid deaths in Alberta among Indigenous people. So I've been in meetings with government analysts who say, yeah, but everything went up during COVID, which is somewhat true. But if you know anything about opioid addictions, once the pandemic's over, you don't say, oh, I'm going to quit opioids and get back to my life. You don't quit opioids. You either get help or opioids quit you. So it is not a very happy situation when we talk about the opioid crisis in Alberta or even across Canada, especially as it pertains to Indigenous people. You talk about how many Alberta deaths there were in response to COVID-19. Any guesses? Well, there's approximately 5,758. And since 2016, approximately 6,594 people have died in the opioid crisis. Anyways, what does all this mean? What does it translate to in terms of Indigenous health? What are the implications for Indigenous populations? Well, it means we die younger. 2016, Alberta was national news when it was discovered that Indigenous Albertans were living 12 years less than the rest of the population. Has it got better? Well, no. Today's life expectancy is 18.2 years shorter for First Nations people living in Alberta. In 2016, the Indigenous infant mortality rate is still twice as high as non-Indigenous Albertans. So, looking at this big picture, some people are reluctant to call Indigenous health a national crisis. Indeed, I've been told not to refer to it that at AHS. Some people are reluctant to call it a violation of basic human rights. But I don't know how anybody can see a group of people living 10 to 18 years less than the rest of the population and regard it as anything but. So how do we move forward as health services, as clinicians? How do we move beyond the Indigenous health crisis? Well, the first thing we need to do is remove the biggest and oldest systemic barriers to healthcare that there is. Well, what barrier is that, you might be thinking? Well, you only need to look at the newspaper headlines to answer that question. The first box here, Brian Sinclair, Indigenous man in Manitoba. He dies in the emergency department. He's a double amputee in a wheelchair. He's presumed intoxicated and he's told to go away. He dies of sepsis, and his body is discovered 34 hours later with rigor mortis in the emergency department. There's an emergency room in BC where the staff were playing Price is Right. They're placing bets on the blood alcohol level of Indigenous patients. This young woman almost died when she was presumed intoxicated, but was actually found to be severely dehydrated. And then this third box here, we have AHS staff in Alberta fired for racial slurs directed at an Indigenous leader. In 2022, we have the McLean study in Alberta. My colleague Patrick McLean. He looked at 11 million emergency room visits. He found that Indigenous patients were consistently triaged as less urgent than non-Indigenous patients who had the exact same diagnosis. Tragic death of Joyce Echaquan in Quebec, where she filmed staff saying horribly racist things to her as she died, saying she was better off dead. A few months after Joyce Echaquan's death, 2 more nurses were fired from that exact same hospital. Jocelyn Ottawa went into clinic for wound dressing on her foot. She said the nurses humiliated her, saying they preferred to call her Joyce. They asked her to sing songs for them in her native language while they laughed. And then she realized that they had taken her phone and they were withholding it for the duration of her appointment. There's an article from the 2020 PHAC study, Public Health Authority Canada, that compared Indigenous women with non-Indigenous women and found a higher prevalence of diagnosed chronic diseases, mental health issues, and many, many others, even when adjusted for similar age, education, income, and location. These are stories that point to a national problem of systemic racism in healthcare. In fact, Indigenous Service Minister Patty Haju attended a public forum following the death of Joyce Echaquan, and she said, "Sadly, this is not shocking to me. Racism is not an accident in healthcare. The system is not broken. It was created this way, and the people in the system are incentivized to stay the same." Well, maybe you're sitting back in your chair now and you're thinking, yeah, but this is all just mainstream media, right? Trying to sell newspapers. Well, numerous independent investigations and commission reports have confirmed it in the past. TRC comes out in 2015 outlining numerous systemic Indigenous health inequities. First People's Second-Class Treatment comes out in 2015 by the Wellesley Institute. Out of Sight comes out in 2017, response to the Brian Sinclair death. Key Health Inequalities, a National Portrait, released in 2018 by PHAC. The Vines Report in 2019, in response to Joyce Echaquan's death. In Plain Sight comes out in 2020, surveying 9,000 people, 84% of whom indicated that they experienced racism in healthcare. This is all fairly new, though, isn't it? The RCAP report, let's not forget, came out 37 years ago. Its final report was 5 volumes, 3,347 pages, documenting discriminant government policy in Canada. And in 2016, 20 years after its release, one of its original commissioners, 72-year-old Paul Chartrand, was quoted as saying, "There's a very powerful lesson in all of this," which is to say today that I don't think anything has changed. Research has shown that stigma, racism, and discrimination can result in chronic stress, increasing what McEwen and Steller called allostatic load, the cumulative burden of chronic stress and life events on our body. This is the physiological wear and tear that chronic stress response has on our bodies. Allostatic load results in dysregulation, inflammation, vascular problems. Over time, this increases the risk of chronic health conditions, cardiovascular disease, mental health issues. Then there are bidirectional relationships between them. Each one of these factors contributes to a cumulative effect, but they also exacerbate each other in what Johnson and Akapchuk called bidirectional relationships. So studies have repeatedly shown that when white people increase their socioeconomic status, their health improves. But when minorities increase their socioeconomic status, their health does not improve. Other studies have shown middle-class people are far more likely to get referrals to specialist treatment. So racism and discrimination in healthcare isn't just about someone's feelings being hurt. There are very real health consequences associated with stigma, racism, and discrimination. And when we think about the vast populations affected by this, we know that a Canadian healthcare system is being burdened down by the very problems caused by systemic racism. So ACEs, we talked about in the beginning, social determinants of health, low socioeconomic status, stigma, racism, and discrimination, they all set in motion the perfect storm that is what I call the Indigenous health crisis, which people are dying faster and younger than the rest of the population. So where do we go from here? Well, Canadians need to understand that colonization was designed to displace and disconnect Indigenous people from their communities and their families and their culture. They need to understand that health inequities are experienced by Indigenous people represent the embodiment of structural and systemic disadvantages that were installed through colonization. We need to understand that poor Indigenous health outcomes are not an accident. The colonial system was designed to oppress, and the poor health outcomes are a direct result of that oppression. And so to reverse these health inequities, we need to decolonize health services. But what is decolonization? Well, Dr. Linda Tuhiwai Smith literally wrote the book on decolonization in 1999. And she said, Indigenous decolonization describes the ongoing theoretical and political processes whose goal is to contest and reframe narratives about Indigenous community histories and the effect of colonial expansion, cultural assimilation, exploitive research, and on often, though not inherent, genocide. But what does this look like in practical application in our healthcare system? Well, the first step to decolonizing healthcare acknowledges that legacy of colonialism in healthcare, as well as the truth and consequences of it. Then it requires collective action, not promises, not commitments, not land acknowledgements, but action to identify and remove colonial systems that continue to act as barriers to adequate Indigenous healthcare. This means removing and replacing policies, procedures that create healthcare disadvantages for Indigenous people. It means addressing racism and discrimination on a systemic level. How can we ever build trust with Indigenous communities if we refuse to embrace the very values we proclaim to uphold as healthcare practitioners? Compassion, safety, accountability, respect. Staff routinely involved with incidents of racism need to go. We need to embrace the reality and let them go instead of protecting the status quo. Rotten apples will fall off growing trees. Finally, it means working with Indigenous communities to find healthcare solutions that work for them. And any steps towards decolonization health need to start with the immediate implementation of TRC's health calls to action. We talk about this a lot in healthcare, but nobody's ever actually read them. I'm not going to read them all, but we can go over the finer points, which is implementing the treaty right to healthcare, establishing goals, measurable action plans, recognizing distinct needs, and establishing funding for healing centers. There's 12,000 residential survivors walking the streets right now. They should have access to healthcare and healing centers that help them get through that trauma and pain. Talked about recognizing Indigenous healing practices. Talked about increasing Indigenous health professionals. Indigenous health, trust in healthcare is broken, and it can be rebuilt with the help of Indigenous health professionals. Talked about medical and nursing school curriculums. Absolutely critical. Before Kamloops 211, I did a presentation about 50 psychiatry residents in Alberta Hospital. And I'm getting all these really blank looks, and I said, how many of you guys actually know what a residential school is? About 50 psychiatry residents, about 3 of them put their hands up. Many of them were from overseas, granted. But we're never going to improve Indigenous health outcomes until all health professionals understand the traumatic history of Indigenous people and the unique health needs they present as a result. Talking about expanding education and awareness of Indigenous health. I'm talking about moving beyond cultural competency in these online learning modules. Talking about learning about the role of trauma in this crisis, the social determinants of health, and the current Indigenous health crisis. Talking about trauma-informed care implementation, a comprehensive strategy to address racism and discrimination, addressing things like unconscious bias. Because empathy doesn't grow in a vacuum, and neither does racism. Racism comes from a lack of understanding. Empathy grows with greater understanding. So we need to facilitate that greater understanding. Path dependency. I found this phrase stuck on a wall in Calgary. I took a picture of it because it is something that I had heard 1,000 times working in New Zealand. I used to do patient death reviews in New Zealand, trying to figure out what happened when a patient died unexpectedly. I would ask nurses and doctors, why was the patient moved here? Why was the patient in restraints? Why would you not take the patient to X-ray first before you did that? And the answer was always the same. We've always done it this way. And researchers like Mark Exworthy have used the term path dependency to describe this phenomenon. And we need to acknowledge that there are changes in healthcare coming, and they're happening as we speak. Change is always challenging, but without challenge, there is no change. And decolonizing health services means that health services will need to change. We need to challenge the belief that healthcare services are static and embrace the reality that health services are dynamic. They're constantly changing, and they need to change faster. And so may we. And so we need to keep a keen eye on change management processes and emphasize the importance of community engagement in this process. I'll talk a little bit about data here. I'm not going to spend a whole lot of time on data. Other than to say that we need more Indigenous data, better Indigenous data, if we're to be making data-informed decisions at a strategic management and operations level. I did want to talk a little bit about best practice, though. We quite often in healthcare talk about best practice. We do this because it's best practice. But the very term best practice is at odds with Indigenous culture and values. Best practice implies one approach is better than another. Indigenous culture and wisdom would never keep score on something as important as something as important as health. All approaches to help those in need would be regarded as valuable or helpful to healing. Best practice can be subjective. Sometimes it's rooted in values, local context, worldview, and perception, what we perceive as valuable. Best practice might recommend targeting those vulnerable in the community, but those identified as most vulnerable in Calgary might be a different population than those perceived as vulnerable in high level. So this is what, yeah, and then there's this recent push to look at wise practices, and this really speaks to programs or interventions that have already proven helpful to Indigenous populations. And this really speaks to the fundamental ways that Indigenous health research is being conducted with an Indigenous perspective. And we need to emphasize the value of qualitative data in Indigenous program development and research, because in a culture that has so much of its identity rooted in oral tradition, it only makes sense to consider individual stories and experiences in program development. It shouldn't be regarded as a credibility deficit, but a strength. We'll talk about the value of user experience. The IPJ projects that I did in 2016 taught us that Indigenous service users will only go to a service if it's delivered in a way that works for them. And if they don't like it, they won't go to it at all, much like this picture here. So it's imperative that we not only listen to our service users, but we learn from them too. And I talk about building resilience through culture and spirituality. When I did those 200 interviews with Indigenous people, I asked those in recovery, what sustained your recovery from addictions the most? And 22% said it was family and friends, the children. 22% said it was getting treatment, a treatment program that was effective. But 35%, by far the biggest percentage, said finding their culture and spirituality was what sustained their recovery the most. So it only makes sense that we build on that strength in our program development and our research and our service delivery. I talk here about ethical space. Ethical space is a process engagement. It's a framework that helps you look at things by examining the diversity of and positioning of Indigenous peoples and Western society in the pursuit of a relevant discussion. Basically, it means listening to each other, acknowledging your differences, embracing them, and then moving forward together. And then two-eyed seeing. This is another way of looking at it, where you're looking at it using the Indigenous perspective with one eye and the Western perspective with the other. And then together you get a full picture of the problem and the solution. So try to move through these slides a little bit faster here, conscious of the time. And I talk about supporting Indigenous communities here. This is me signing an MOU with Enoch Cree Nation that was signed by 4 levels of government. People flew in from Ottawa to sign this. But it was a partnership in Indigenous healthcare. And so we need to replace these kind of paternal funding mechanisms with Indigenous health partnerships, collaborations that are based on mutual respect and understanding. That's where that saying comes from, nothing about us without us. Also talks about, supporting a shift from crisis response to upstream prevention. My mother was working with a 6-year-old boy in a reserve who had been caught drinking at school. She said, Taniga, Amina itotamen, why are you doing that? And he said, Nimichi, Magina nida Indian, because I'm an Indian, I'm supposed to. And what's shocking about that story is not just that he started experimenting with alcohol at such a young age, but rather that he had already operationalized drinking as part of his belief system and identity. So we need to start looking at upstream solutions in terms of prevention instead of crisis response. There's little support for Indigenous prevention programming, so we need all levels of government back at that table to discuss sustainable prevention funding, because as we all know in healthcare, prevention is always better than the cure. Coming to the end here, so the trauma of losing your culture, your language, your identity, the trauma of neglect, emotional, physical, and sexual abuse, coupled with the loss of parental role models. Many Indigenous people who were abused and neglected in residential school went on to abuse and neglect their own children. So many had their children taken away from them. And so the Indigenous trauma cycle repeats itself. There are now more Indigenous people incarcerated in Canada than there are Black people incarcerated at the height of the South African apartheid. There are more Indigenous children in foster care than were ever in care at the height of residential schools. Indigenous youth are the fastest growing segments of Canada's population, and they're top of the list, most Canadians likely to die young. Sorry. The need for active steps towards reconciliation and Indigenous health isn't going away. It's growing exponentially. And now it's easy to hear all these heartbreaking realities and become overwhelmed with the sheer scope of the problem, to feel sad, angry, or to lose hope. But I assure you there's much to be hopeful for. The recovery in Kamloops and Cowessess shocked the country. There are now active ground-penetrating radar searches underway all across Canada. And what we need to understand is the voices of these children have been heard, and they woke a sleeping giant. From coast to coast and around the world, people were standing up and they were speaking out and they were saying, every child matters. And many Canadians were hearing and seeing that truth for the very first time. And so the journey to reconciliation can begin. There's a quote from Senator Marie Sinclair, which he says, the road we travel is equal in importance to the destination we seek. There are no shortcuts. And when it comes to truth and reconciliation, we're all forced to go the distance. Sage words. So what difference can I make? What difference can I do? Well, you can help others recognize that the Indigenous health crisis is real and that it's a human rights issue. We've done study after study for 25 years, and they've all said the same thing. We need action. We need action beyond inquiries, beyond political lip service, and that only comes when you recognize Indigenous health inequity for the human rights violation that it has been and continues to be. You can help others understand the importance of trauma-informed care and the role of social determinants of health. You can be an ally to Indigenous people. You can stand up and speak out against racism wherever and whenever you see it. And being an ally means being an ally all the time, not just when you're standing at the podium or sitting in the boardroom. Identify opportunities in your organization to decolonize health services for Indigenous patients. Consider developing a reconciliation action plan that incorporates Indigenous truth and ways of knowing. You can help build Indigenous trust in healthcare and make the healthcare system a safe place for Indigenous people. Last couple of slides, I promise. I apologize for using this picture 3 times. It's actually one of only 3 pictures I have from my childhood. The human brain is remarkable. It'll do anything it can to protect us from trauma. I remember the trauma of my childhood like it happened yesterday. But my little sister remembers nothing of her childhood. Her little brain had hidden her trauma so well that even her good memories are gone. In the beginning of this presentation, I told you about my mother, the trauma she experienced as a child, and I told you about the trauma her children experienced. So where are they now? Well, both my sisters have long histories of dysfunctional relationships and domestic violence. Both sisters have been to addiction treatment more than once. Both my sisters have had their children taken away and placed in foster care at one time or another. One of my sisters recently lost a child to the opioid crisis. We've all have or had struggles with physical health, mental health, substance abuse, even the criminal justice system. You drown not by falling in a river, but by staying submerged in it. A quote there from Paul Coelho. Escaping the trauma of our childhood has been difficult for all 3 of us, and some of us indeed remain submerged. Through the course of my adult life, I've learned many things. I've learned that healing is a lifelong process. Some days are harder than others, but it gets easier over time. I've learned about the power of unconditional love and the healing that can only be found in forgiveness. And like my mother before me, I too found a way out. I followed her footsteps through university, and I built a career that has taken me around the world. Like my mother, I too achieved many of the dreams I once thought impossible. Once an angry and violent young man with multiple arrests, I'm now a warm and loving father who's built a safe and happy home for his family. And this has become my transcendent purpose, my reason for being. The Indigenous cycle of trauma may not stop with my sisters and their children, but it'll certainly stop with me and mine. I want to be clear now. Indigenous truth and reconciliation is not an attempt to make you feel guilty. It's not an effort to instill you with a sense of shame. Shame is the enemy of reconciliation. Shame replaces conversations with silence. Indigenous truth and reconciliation is not a cry for sympathy or pity. It is a plea for understanding. Without conversations, there will be no understanding, and without understanding, there will be no reconciliation. Please understand that you have an important role to play in Indigenous reconciliation, but it's up to you to discover what your role will be. I'd like to leave you with a final thought on the traumatized mice and the cherry blossoms I mentioned at the beginning of this presentation. When the traumatized mice were sprayed with the cherry blossom scent without the electric shock, they eventually stopped reacting to it. Their brains rewired the response to the point their sperm no longer held that epigenetic signature of the trauma response. Now it's early days, but the study suggests once trauma is removed from the equation, traumatized brains can be reprogrammed, so we no longer live in fear. Well, maybe we can recover from trauma to the point it disappears from our DNA. Maybe as health professionals, we can stop the cycles of Indigenous trauma from being passed on to the next generations. Maybe as clinicians, we can ensure the next generation has greater health equity so that we can all move towards reconciliation, not just as individuals and families, but as friends, neighbors, and communities. I want to thank you all for staying on a little bit late. I know I went over time, but I want to thank you for being here today and for listening. Kinanos Kamitnan, hi. Thank you. And it's been a pleasure.
That was fantastic, Randall. Thank you very much for taking the time to bring that to us. And I love the wrap up. I had a question about the epigenetic study, and you just tied it all together. It was great. We do have a few questions from the audience. So for those of you that are still with us, thanks for hanging around. And for those obviously that have left, this will still be kind of recorded and put up on our website. Okay, Randall. So one of the first questions came with your IPJ projects that you had ran back in 2016. Did you also have the opportunity to interview and quantify legacies of trauma among Indigenous peoples who were not unhoused or incarcerated? Do they demonstrate different patterns of trauma than the ones that you had spent time with in your study, and maybe reflecting on other research that you're familiar with?
That's a really good question. But simply put, what we were trying to quantify was in healthcare, I'm sure you're familiar with the term, the frequent flyers. And we were trying to quantify, what the needs were of these frequent flyers, why they're being treated 5 and 6 times, and why we were having absolutely no success with them. And so the homeless population seemed to be the most logical fit for that, with, the obvious substance abuse problems, but also it made for an easily accessible convenience population, or convenience sample. So that was the direction that we took. My PhD studies starting in the fall, but the longer term goal is to look at the other challenges that we have in non-homeless populations.
Thanks. Okay, so this is from somebody who's working in a pediatric practice and providing health education to families across Alberta. One of the goals of our programs is to help support equity and accessibility to health education. Any insight into steps that they can take to start building those relationships with Indigenous communities to support families?
Yeah, absolutely. What we found more recently, we've tried to engage Indigenous populations in these education and learning sessions, and we weren't having much success. It was when we partnered with an Indigenous nation, which was Stoney Nakoda. And when they saw, oh, this isn't just some white guy in a lab coat lecturing us, it's actually going to be a lady from the reserve who's also involved in this work. She's going to be presenting too. We started to see those numbers tick upwards. We started to see people stay for the entire sessions. And now that we've kind of adopted that as standard practice, our numbers have absolutely gone through the roof in terms of community participation, community engagement. So we really see that as one way that you can reach a wider audience and keep that captive attention. So I think incorporating Indigenous partners in these kind of education sessions, you know, trying to tailor your presentation or your engagement session specifically to Indigenous populations obviously is going to make a difference. I've presented to dietitians where they're going on and on about carbohydrates and protein diets and everything else, and this is what you need to do for your child. And it's just not realistic for somebody who has challenges just putting basic food on the table. And so it's trying to come up with other solutions that might be out of the box. How can you help them get the resources they need to make the health choices and the health changes that they need to? And I think the answer would be much the same in the world of physiotherapy. You know, it's what is your what is your circle of resources look like? How can we work together to make sure that we're solving this problem and getting you the exercises that you need or the services that you require, but working with the patient, not just saying you should go out and do this and, you know, grab a $500 a month gym membership and do a lot of leg exercises or what it might be, you know, like you have to meet with them, discuss what the resources are, and then try to come up with a solution within that resource framework.
Yeah, and I think that's something that physiotherapists, I mean, try and do, I think, with patients as a whole. But I do think it is definitely a different learning experience, I think, when you're working with somebody with that Indigenous background, living in community, trying to get an idea, kind of what does that really look like, you know, especially if we're, you know, I know some physios are providing remote services to those communities. So, I mean, they beam in like we are today. It doesn't really give you, I think, I mean, I think it would be challenging to get a really good idea or understanding of what, you know, what that really looks like for them in their home or in their community and what resource they have access to. So I think it really takes, I think, a little bit more time and effort to kind of build kind of that picture before you know, start spouting off exercise and education advice.
Get a membership at the local pool and 6 days a week go swimming. There's no pool on reserves. So,
Yeah.
but one thing I really want to, this is probably the best answer I can give to that question, is become very familiar with Jacob's principle. And so through that, you can write a letter saying this child needs a gym membership. This child needs access to a swimming pool. This child needs these bands that he can increase mobility with, or whatever it is. They will pay for it so long as a letter writes a clinician. But most Indigenous patients don't know that. Most clinicians don't know that. But there is literally a blank check for you to get these resources, so long as it comes with a letter from a clinician saying it's an absolute necessity for your health. And what you can do is develop like a form letter and just leave kind of a blank paragraph in the middle, and then you just write, copy paste from your patient notes in there, click send it off to the patient and to NIHB, and they'll get it funded. They'll get that service funded in most cases. Jordan's principle.
Jordan's principle, yeah.
Yeah. Running with a coffee here, so.
It's been a rough morning already. Okay, so yeah, all the questions we had for today, I think we need to kind of wrap this up. But yeah, Randall, that was amazing webinar. So thank you very much for coming in today. I think kind of all those who attended, and I think all those who are going to watch later on the video will, find it very, very informative, very valuable. So yeah, thank you very much for your time and your expertise in this area.
Wonderful. I hope you guys all have a great day. I hope you guys, and if you missed something, go back, watch the recording. My email's on there if you wanted to reach out and ask me a question that pops up later that we didn't answer here. And again, thank you all for being here. Thank you all for listening.
Thank you.